Think about this for a second. Roughly 1 out of every 15 people living with diabetes will experience a foot wound at some point.
That's a sobering statistic.
It really is. And the cost, I mean, to the U.S. healthcare system, it's huge. Somewhere between $9 and $13 billion a year.
Wow. That's staggering.
But here's a really critical point. A massive 85% of lower limb amputations, they're triggered by these wounds not healing properly.
Maybe 85%.
Yeah. And just to give some context on how serious this all is, diabetes actually causes more deaths than breast cancer and AIDS combined.
That puts it into perspective.
And, get this, 60% of non-traumatic lower limb amputations in the U.S. happen to people with diabetes.
So it's a major, major issue.
Definitely. But, okay, here's the encouraging part. The good news in all this is that when they're caught early, most of these diabetic foot wounds are actually quite manageable.
Right, if you have a well-thought-out strategy.
Exactly. A strategy.
But, even though those initial steps can seem straightforward, I think many people, patients, and maybe even some clinicians, feel overwhelmed.
How so?
Well, just trying to understand the complexities of wound care, especially for something like a diabetic foot wound. There's a whole different language, lots of terms.
Yeah, the jargon.
Right,
Yeah.
all these different ways to score wounds, and then a seemingly endless list of treatment options. It can feel like you're trying to navigate a maze, really.
Okay, so let's try to unpack that together today. Our goal here is to, simplify things a bit.
Good plan.
You've shared a really valuable resource with us, Chapter 21 from the textbook Hyperbaric Medicine Practice. The chapter's called Strategic Approach to Diabetic Foot and Other Wounds.
Yes, it lays out a pretty comprehensive framework.
It does. It seems to cover not just diabetic foot wounds, but wounds more generally. So we're going to dive into that, try to pull out the most important bits.
Sounds good.
We'll focus on how to evaluate these wounds, the different ways to manage them, the role of prevention, which is huge, and even when things like hyperbaric oxygen might come into play.
Okay.
The aim is to give you clear, actionable insights, hopefully without getting totally bogged down in, excessive detail.
In connecting this to the bigger picture, the chapter really emphasizes that almost all diabetic foot wounds happen because of what they call a troublesome triad.
Troublesome triad. Okay, what's that?
It's basically a combination of 3 things.
Okay.
Usually some kind of foot deformity, a deep infection, and what's called ischemia hypoxia.
Ischemia, hypoxia. So not enough blood flow and oxygen.
Exactly. A lack of sufficient blood flow and oxygen getting to the area. Now, it's important to understand that while nerve damage, neuropathy is super common in these situations.
Right, you hear about that a lot.
You do. But it's considered more of an indirect contributor. It often leads to delays in people seeking care, maybe because they don't feel the initial injury, and it can certainly contribute to deformities over time.
Ah, okay. So it's involved, but not the direct cause of the wound itself.
Usually not the direct cause, no. Recognizing this triad helps you and your doctor really target the root causes, not just, treat the surface symptoms.
That makes sense. Target the underlying problem. So let's start with the basics then. What exactly are we talking about when we say wound?
Yeah, the chapter makes a helpful distinction there. We often use wound and ulcer kind of interchangeably, right?
I think so, yeah.
But they suggest thinking of wound as the broader term. So any break in the skin surface could be just a scratch, or it could be something much deeper involving muscle, bone, even joints.
Okay, so wound is the umbrella term.
Pretty much. Whereas ulcer, they often use that to mean a more surface-level wound, and it's typically linked to specific causes like abnormal foot mechanics.
Like from those deformities you mentioned.
Exactly. Or nerve problems, poor circulation, or just, too much pressure on one spot for too long.
Got it. So that distinction's helpful. Which brings us to the next logical question. How do we actually assess these wounds properly?
Right. And the chapter highlights, first off, the vital role of getting a good history.
Okay, like asking the right question.
Yeah. Understanding when the wound started, how long it's been there, what symptoms the person's having, what treatments they've already tried, that sort of thing.
Makes sense. History first.
And then, of course, a thorough physical examination. But they also introduce a really useful tool called the Long Beach Wound Score. LBWS for short.
LBWS. Okay, tell me about that. It sounds like a practical way to kind of quantify things.
It really is. It's a straightforward 0 to 10 point system, simple scale. And it looks at 5 key factors.
5 factors. What are they?
Okay, so first is perfusion. That's the blood supply to the wound area. Second, infection or bioburden, basically. How much bacteria is present.
Okay, perfusion, infection.
Third is the depth of the wound. Fourth is the appearance of the tissue right at the base of the wound. What does it look like?
Healthy,
Yeah,
unhealthy, that kind of thing.
exactly. And fifth is the size of the wound. Each of these five gets scored from 2 points, which is the best, down to 0, which is the worst.
2 down to 0 for each of the 5.
Right. And they even mention you can use half points if something falls, in between the main scores.
Flexible.
Yeah. And the idea is this isn't just about getting a number. It's like a roadmap. It helps track progress or identify if a wound isn't responding and maybe needs a different approach.
I like that, a roadmap.
And what's interesting here is how the LBWS kind of pulls together key elements from other classification systems that are more commonly used.
Oh, like which ones?
Well, things like the Wagner grades, which mainly look at depth and infection, or the MPUAP stages, which are mostly for pressure ulcers.
Okay.
Then there's the University of Texas Diabetic Wound Classification that focuses on depth and infection specifically in diabetic foot ulcers.
Oh.
And the IDSA system for grading diabetic foot infections.
So lots of other systems out there. What's the issue with them?
The challenge often with many of these older systems is they tend to focus on just one aspect, like how deep the wound is maybe, or just whether an infection is present or not.
Kind of one-dimensional.
A bit, yeah. Or they just note if something is there or not without really grading how severe it is. Plus, for quite a few of them, there actually isn't a lot of solid evidence showing how well they predict healing outcomes.
Ah, okay. So the LBWS tries to be more comprehensive.
Exactly. By scoring each of those 5 components, perfusion, infection, depth, base, size, on that 0 to 2 scale, it gives us a more objective way to compare different wounds.
And track changes over time.
Absolutely. That's really important. Monitor how a wound is changing. The chapter even breaks down the total score into categories.
Oh, yeah. How does that work?
So wounds scoring between 7.5 and 10 points are considered healthy. Makes sense, right? High score, healthy wound.
Right.
Then problem wounds fall in the 3.5 to 7-point range.
Okay, the middle ground. Needs attention.
Definitely needs attention. And then wounds scoring between 0 and 3 points are classified as futile.
Futile? That sounds pretty serious.
It indicates a very challenging situation, yeah.
Yeah.
And this categorization really helps guide the treatment strategies.
Okay, so let's talk about those strategies. For those problem wounds, the ones scoring between 3.5 and 7, what does the chapter suggest?
It outlines 5 critical strategies for managing them effectively. 5 key areas to focus on.
5 strategies. Okay, what's the first one?
The first one really focuses on the wound bed itself, the actual tissue at the base of the wound, managing that.
Okay, the wound bed, and how do you manage that?
The main approach, according to the chapter, is debridement, cleaning it up, essentially.
Debridement, right. I've heard that term. Are there different kinds?
There are. They describe 5 main types.
Mm-hmm.
First, there's sharp debridement. That's where healthcare professionals use instruments, scalpels, scissors, curettes, things like that.
Specialized tools.
Right, to carefully remove surface issues like calluses or dead necrotic tissue around the edges.
Okay. Sharp debridement. What else?
Then there's autologous debridement. That uses the body's own enzymes, along with moist dressings, to help clean the wound naturally.
So letting the body do the work.
Kinda, yeah. Third is enzymatic debridement, which uses specific prescribed ointments or solutions, like collagenase Santel is a common brand name to break down that dead tissue.
So using enzymes.
Fourth is pulsatile lavage. That's a type of hydrotherapy using pressurized fluid, like saline, to wash out the wound.
Like power washing, but gentle.
Sort of. And then, surprisingly perhaps, there's biological debridement.
Biological? What's that involve?
Medical-grade maggots.
Maggots, really?
Yep. They're actually FDA approved for this. They selectively eat the dead tissue and leave the healthy tissue alone. Monarch Labs is a company that provides them.
Wow. Okay, that's fascinating.
It is. They also mention, of course, more extensive surgical debridement that's done in an operating room for deeper problems involving bone or joints.
Makes sense for complex cases.
And they even discuss amputation as technically a way to manage the wound base in certain severe situations, ranging from minor procedures on toes or the forefoot up to more major amputations. Sometimes they need to use really creative surgical techniques called flaps to get things closed.
Okay, so debridement is key for the wound base. What's strategy number 2?
The second crucial strategy, and this is one the chapter emphasizes is often not given enough attention, is protection and stabilization.
Protection and stabilization. Why is that so important?
It's all about reducing movement and shielding the wound from further injury or pressure.
Okay. What kind of things does that involve?
Well, there's a sort of hierarchy. It starts with simple padded dressings like a Robert Jones wrap. Then you might move up to splints or those removable walker boots.
Cam boots?
Yeah, cam boots, controlled ankle movement boots, then casts, and in some really complex situations, even external fixation devices like metal frames outside the limb.
External fixation.
Wow. Yeah. But they specifically caution against using internal fixation, like plates and screws, right at the wound site if possible.
Why is that?
High risk of the hardware failing or getting infected in that environment.
Ah, okay. That makes sense. So the main idea is just keep it still, keep it safe.
Pretty much. Movement can really mess up the healing process. It can tear tiny new blood vessels that are trying to form, and it just creates an environment where bacteria can easily get in and thrive.
Right. Stop disrupting the healing.
Exactly. Now, they do acknowledge that sometimes a tiny bit of controlled motion, like you might get with negative pressure wound therapy, might actually help stimulate blood vessel growth angiogenesis.
Okay. A little caveat there.
Yeah, but they also warn you have to be careful with things like negative pressure, because it can sometimes cause iatrogenic complications problems caused by the treatment itself, like blisters or pressure injuries if it's not applied correctly.
Good point. Always a balance.
Oh.
What about casts? You mentioned casts.
Right. They discuss the total contact cast, the TCC. It's often used specifically for diabetic foot ulcers on the bottom of the foot.
How does that work?
It works by distributing the pressure really evenly across the whole sole of the foot, taking pressure off the ulcer area.
Sounds effective.
It can be, but they also point out some downsides. You usually need to change them frequently, like every week or two. There's a risk of a hidden infection developing underneath that you can't see.
Ooh, yeah. That's not good.
No. And a big one. There's a high chance the ulcer will just come back if the underlying foot problem, like a deformity, isn't also addressed. The cast protects it while it heals, but doesn't fix the root cause.
Okay. So protection and stabilization is strategy 2. What's number 3?
The third strategy shifts the focus more to the patient's overall health, appropriate medical management.
Right. Looking beyond just the foot.
Exactly. This really highlights how crucial a team approach is, involving the patient's primary care doctor, specialists like endocrinologists, cardiologists, kidney doctors.
The whole team. Why is that so critical?
Well, they stress the need to get any underlying medical conditions, comorbidities, as well controlled as possible. Things like diabetes itself, obviously getting glucose and HbA1c levels optimized,
Makes sense.
but also looking at heart problems,
Huh?
checking things like BNP levels or doing echocardiograms, and kidney function, BUN, creatinine levels. They note that a high percentage of people with diabetes also have kidney disease, which can really challenge wound healing.
Yeah, everything's connected.
It really is. They
Yeah.
talk about defining a healthy host, and they introduce another scoring system here called the wellness score.
Another score. Okay. How does this one work?
It's also a 0 to 10 point system, but it assesses the patient's general health status. It looks at things like their ability to do daily activities, how well they can walk, what other medical conditions they have, lifestyle factors like smoking or if they're on immunosuppressant drugs, and their neurological function.
So a snapshot of their overall wellness.
Exactly. And this score helps the healthcare team figure out how much collaboration with different specialists might be needed. It helps categorize the patient as generally healthy, impaired, or decompensated.
Guiding the team approach.
Precisely.
Yeah.
And under this medical management umbrella, they also really emphasize the role of a clinical nutritionist.
Nutrition. Right. Often overlooked.
Very often. Addressing malnutrition is key, and surprisingly, this can happen even in patients who are overweight. You look at things like albumin and prealbumin levels in the blood.
So you can be overweight but still malnourished.
Absolutely. And they outline a range of nutritional interventions, starting with simple oral supplements, maybe moving to nasogastric tubes or PEG tubes for longer-term feeding, and in severe cases, even parenteral hyperalimentation IV nutrition.
Okay, a whole hierarchy there too. So that's medical management. What's strategy number 4?
Strategy 4 is the selection of optimal wound dressing agents.
Ah, dressings. This always seems like the most confusing part. There are so many.
Tell me about it. The chapter points out there are literally thousands of different dressings available, more than 3,000 options. It can be totally overwhelming.
Yeah, how do you even choose?
Well, they try to simplify it. They use lumpers approach, grouping dressings into 4 main categories. This helps you focus on the function of the dressing rather than getting lost in brand names.
Okay, 4 categories. Let's hear them.
First, there's just moist gauze. Basic, right? Saline-soaked gauze. Maybe gauze with mild antiseptics like acetic acid or Dakin solutions, sort of the fundamental standard.
The workhorse.
Pretty much. It's versatile, but the downside is it often needs to be changed frequently, sometimes multiple times a day.
Right. Okay, what's the second group?
Second group is impervious or semi-impervious coverings, and also biologic dressings. Think thin films, hydrocolloids, skin substitutes.
Okay, when would you use those?
These are often used for healthier, more superficial wounds, maybe wounds that have good blood flow already, or for covering skin graft donor sites that usually don't need changing as often.
But maybe more expensive.
They can be, yeah. Third category, absorbents. This is all about managing drainage or exudate from the wound.
Okay, so for wetter wounds.
Exactly. This includes things like sponges, alginates, foams, meshes, hydrophilic dressings, hyperosmolar dressings, and the ultimate absorbent really is negative pressure wound therapy, or NPWT.
Woundivacs.
Right, often called wound vacs. NPWT is great at removing fluid, and some systems even allow for insulation washing the wound with fluids or antimicrobials while the vacuum is running.
Okay, absorbents. And the fourth category.
The fourth group is salves and ointments. These might be plain, like petroleum jelly, or they might have added ingredients like antimicrobials, enzymes, steroids, or even growth factors.
And when are these used?
Usually for healthy superficial wounds that are in the final stages, getting ready to epithelialize for the new skin to grow over. The costs here can vary wildly depending on what additives are in them.
Got it. So 4 basic groups: moist gauze, coverings, absorbents, and ointments.
Right? And the key takeaway is that the best dressing depends entirely on the specific characteristics of the wound at that moment, and it will likely need to change as the wound heals or changes.
Dynamic process. Okay, that makes sense. What's the fifth and final strategy?
Strategy number 5 is wound perfusion and oxygenation.
Ah, back to blood flow and oxygen. This sounds critical.
Absolutely essential.
Yeah.
This is all about making sure the wound is getting enough blood supply and enough oxygen to fuel the healing process and fight off infection.
And how do you improve perfusion and oxygenation?
This strategy often involves using several different tactics together because they can be complementary.
Okay, like what?
Well, they mentioned things we touched on under medical management, like improving heart function if that's an issue, or reducing any swelling or edema that might be compressing blood vessels,
Right.
using local measures to help dilate blood vessels near the wound, and then, more invasively, revascularization procedures, things like bypass surgery or angioplasty and stenting, to open up blocked arteries in the leg.
Surgical options to restore flow.
Exactly. And this is where hyperbaric oxygen, HbO2, also fits in as a way to boost oxygen delivery.
Okay, HbO2 comes under this strategy.
Yes. Alongside various pharmacological agents, medications.
What kind of medications?
Things like antiplatelets, aspirin, clopidogrels to stop platelets from clumping together and forming clots, anticoagulants, heparin, warfarin, newer agents to thin the blood.
Preventing clots.
Right. Even things like low molecular weight dextrin, which is a plasma expander, or pentoxifylline, which helps red blood cells become more flexible to squeeze through narrow vessels, and sometimes local vasodilators like nitroglycerin paste.
Wow, a whole arsenal of drugs.
Yeah, and it's interesting how they explain that because these different drugs work through different mechanisms, they're often used in combination to get the biggest impact on improving blood flow.
Okay, so that covers the 5 main management strategies for those problem wounds. Now, you mentioned hyperbaric oxygen fits into that last strategy. Let's dive a bit deeper into that.
Definitely. The chapter really emphasizes, again, that getting more blood flow and oxygen to the wound is absolutely critical for healing and for controlling infection.
Makes sense. Cells need oxygen to work.
Precisely. And when the body's natural ability to deliver enough oxygen isn't meeting the demands of the healing wound, especially in wounds that already have poor blood flow, that state of ischemia hypoxia we talked about.
Right, not enough blood, not enough oxygen.
That's when HbO2 can become a really valuable tool because it dramatically increases the amount of oxygen dissolved in the blood plasma.
How much of an increase are we talking?
Well, under normal air pressure, oxygen is mostly carried by hemoglobin in red blood cells. Under hyperbaric pressure, breathing 100% oxygen, you can dissolve a whole lot more oxygen directly into the plasma. This allows oxygen to reach areas that the red blood cells might not be getting to effectively due to poor circulation.
Ah, okay. It bypasses the red blood cell traffic jam, so to speak.
That's a decent analogy, yeah. They even mention this hypothesis that a wound might need as much as a 20-fold increase in blood flow compared to healthy tissue to heal effectively. That's a huge demand.
20 times. Wow. How do you know if a wound isn't getting enough oxygen?
That's where those transcutaneous oxygen measurements, the TCMs, come in.
Right, you mentioned those earlier, measuring oxygen through the skin.
Exactly. It's like taking the oxygen pulse of the tissue around the wound. They refer to research, particularly by Dr. Thomas Hunt, showing that you generally need oxygen levels or partial pressures of around 30 to 40 millimHg in the tissue for normal healing to occur.
30 to 40. Okay.
So if TCM testing shows low oxygen levels around the wound, but maybe carbon dioxide levels are normal, meaning waste is getting removed,
Oh.
okay, that's a key indicator that the problem is oxygen delivery, and HbO2 might help.
Low oxygen, normal CO2 points to an oxygen delivery issue.
Right, and what's really interesting physiologically is the difference in how oxygen and carbon dioxide move through tissues. Carbon dioxide diffuses about 20 times more easily than oxygen does.
20 times easier for CO2.
Yeah. So think about it. Your lungs are great at getting rid of CO2 and bringing in O2, but at the capillary level, in the tissues, if the circulation is poor, it's much harder to get enough oxygen in than it is to get the CO2 out.
Okay, I see. So even if CO2 is getting out, oxygen might still be struggling to get in if blood flow is bad.
Exactly. Which is why using TCMs measuring oxygen levels while the patient breathes normal air, and then again while they breathe oxygen inside the hyperbaric chamber, is such a well-supported way to make decisions about HbO2.
So you test them both ways.
Ideally, yes. It helps predict response. The chapter highlights studies showing a really impressive 88% healing rate in these difficult problem wounds if the TCM levels go above 200 millimHg during the HbO2 treatment.
200 millimHg inside the chamber.
Right. Even if their oxygen levels were quite low when they were just breathing regular air outside the chamber, it shows the potential for HbO2 to overcome that oxygen delivery problem.
That's compelling data. 88%.
It is. And beyond diabetic foot wounds, they also list a number of other conditions where HbO2 is considered beneficial, often standard of care.
Like what else?
Things like severe flesh-eating infections, clostridial myonecrosis, necrotizing fasciitis, chronic bone infections that haven't responded to other treatments, chronic refractory osteomyelitis.
This serious stuff.
Very serious.
Yeah.
Also, crush injuries, compartment syndromes, acute peripheral artery ischemia like a suddenly blocked artery in the limb, threatened skin grafts or flaps, certain vasculitis wounds, severe burns, frostbite, even things like Fournier's gangrene.
So a pretty wide range of applications where oxygen is critical.
Absolutely. They also describe the typical stages of healing you might see with HbO2. It's not always instant improvement.
What happens?
Sometimes the wound might even look a little worse initially, or just stay the same. It's called the latency phase. It can last 10 days, maybe up to 3 weeks.
Latency, so nothing seems to be happening.
Visibly, maybe not much change in size. But during this time, the patient might notice less pain, less drainage, less redness or swelling around the wound, less odor. Subtle signs that things are improving metabolically.
Ah, okay. Under the surface changes.
Right. Then after that latency phase, you typically start to see angiogenesis, the growth of healthy new granulation tissue, those little red bumps filling in the wound base.
Angiogenesis. New blood vessels.
Exactly. And finally, epithelialization, where the new skin starts to migrate across that healthy base, closing the wound up. It's really a continuum, but you can often identify these phases.
Okay, that's helpful to understand the timeline. What about guidelines? When is HbO2 generally recommended for diabetic foot wounds?
Well, the chapter discusses clinical practice guidelines, like those from the Undersea and Hyperbaric Medical Society. They generally support using HbO2 for more severe diabetic foot wounds specifically, those classified as Wagner grade 3 or greater.
Wagner grade 3 or higher. What does that mean again?
A Wagner grade 3 typically involves a deep ulcer that goes down to bone, or involves an abscess or osteomyelitis, bone infection. Grade 4 would be gangrene of part of the foot, and grade 5 is extensive gangrene of the whole foot.
Okay, so pretty serious wounds.
Definitely. The guidelines often recommend considering HbO2 after any necessary surgical debridement has been done, or if the wound hasn't shown significant improvement after at least 30 days of good standard wound care.
30 days of no improvement, then consider HbO2.
That's a common threshold, yeah.
Yeah.
They do note, however, that there's less strong evidence to support using it routinely for less severe wounds, like Wagner grade 2 ulcers, which are deeper than superficial but don't involve bone or abscess.
So focus on the more severe cases.
Generally, yes. Now, they also briefly touch on some controversy, some more recent studies that have questioned the benefit of HbO2.
Oh, what's the issue there?
Well, the authors of the chapter critique some of those studies, pointing out potential weaknesses in their methodology. For instance, some studies included a large number of those less severe Wagner grade 2 wounds, where the benefit is less clear to begin with.
Diluting the potential effect?
Potentially, yeah. And maybe not fully accounting for whether patients in the studies truly had that troublesome triad, particularly the ischemia hypoxia component that HbO2 is designed to treat. or maybe not ensuring adequate debridement or offloading first.
So, methodological concerns with some of the negative studies.
That's the perspective presented in the chapter, yes. It highlights the importance of selecting appropriate patients, those with significant hypoxia documented by TTMs, usually Wagner 3 or higher, and integrating HBO2 into a comprehensive treatment plan.
Right. It's not a magic bullet on its own.
Not at all. It's an adjunct therapy. So how do they recommend actually using it in practice?
Yeah, what's the typical approach?
They outline an algorithmic approach, often for acute limb-threatening wounds in the hospital, or maybe severe problem wounds, like LBWS 3.57 or Wagner 3 to 4, where TCMs justify it. They might start with more frequent treatments, maybe even twice a day.
Twice a day initially.
In some acute situations, yes. Then transition to daily outpatient treatments. They generally recommend a course of around 14 to 21 treatments initially to really stimulate that angiogenesis, the new blood vessel growth.
Okay, a couple of weeks to get things going.
Right. And then you reassess. They also have a specific algorithm for what they term end-stage wounds,
Yeah.
maybe LBWS score 2.5 to 4. Really challenging situations.
A futile category almost.
Getting close to it. Here, they really emphasize using the wellness score and also a goal score, which assesses patient goals and motivation to help make that difficult decision. Is limb salvage a reasonable goal here, or is amputation a more realistic and potentially better outcome for the patient's overall quality of life?
A very patient-centered approach.
It has to be.
Yeah.
And if they do attempt salvage in these very difficult cases, they list 5 key considerations.
5 things for end-stage salvage.
Yeah. 1, optimize perfusion and oxygenation to the absolute maximum possible. 2, consider last resort revascularization procedures if feasible. 3, use minimally invasive or KISS, keep it simple surgically, techniques if surgery is needed. 4, sometimes allow for secondary intention healing, just letting it heal slowly on its own if it's stable. And 5, even consider the possibility of the patient living with a small, stable, well-managed chronic wound if complete closure isn't achievable, but the limb is otherwise functional.
Wow. Really thinking outside the box there?
Sometimes you have to in complex cases.
Yeah.
They also make an important point about that Wagner grade 3 definition.
What about it?
The traditional surgical definition often implies immediate infection or abscess, but insurance criteria, like Medicare's for covering HBO2, often require that 30-day period of failed standard care we mentioned.
Ah, a potential mismatch between clinical judgment and coverage rules.
Exactly. It can be a practical hurdle sometimes. However, they do emphasize that immediate HBO2 is definitely justified and usually covered in certain emergencies, like necrotizing fasciitis, or a failing skin graft or flap, or that acute peripheral artery ischemia, critical situations.
Okay, that clarifies the HBO2 picture significantly. Now let's shift gears a bit. What happens after a wound has finally healed? That's not the end of the story, right?
Absolutely not. The chapter really stresses that preventing new wounds or preventing the old wound from coming back is absolutely vital. Paramount, really.
Prevention is key.
It's everything, almost, because the risk factors often remain. They identify 5 main risk factors that make people with diabetes much more likely to develop foot wounds in the first place.
5 key risks. What are they?
Okay, number 1, peripheral artery disease, that poor circulation we've talked about. 2, having had a foot wound before. History matters.
Once you've had one, you're more likely to get another.
Much more likely, yes. 3, having had a previous amputation, even a minor one. 4, having a foot deformity, bunions, hammer toes, Charcot foot, etc. And 5, having neuropathy, that nerve damage leading to loss of sensation.
Okay, PAD, previous wound, previous amputation, deformity, neuropathy.
Right. And the more of these risk factors someone has, the higher their overall risk. It's cumulative.
Makes sense. So how do you address these risks? What are the prevention strategies?
They outline 4 main pillars of prevention.
4 prevention strategies. Let's go through them.
First, and they say this is really the foundation, is education.
Education for who? The patient, the doctor.
Both. Making sure healthcare professionals understand the risks and know how to do thorough foot exams, but also, crucially, patient education.
What should patients be educated on?
Understanding their own risk factors, the importance of daily self-foot checks, knowing when to call the doctor, but also managing the bigger picture. Weight management, quitting smoking, keeping blood sugar controlled, staying appropriately active, and really knowing the do's and don'ts of foot protection. There's actually a helpful table in the chapter outlining these.
Practical do's and don'ts.
Yeah. And they also mention using those wellness and goal scores again here to help tailor the education. For example, setting realistic activity goals based on their ability, or figuring out how often someone needs follow-up based on their understanding and how well they're sticking to the plan.
Personalizing the education. Good. What's the second prevention strategy?
Second is focused on skin and toenail care.
Seems basic, but I guess it's really important.
Hugely important. It's all about keeping the skin healthy and intact, preventing those small injuries, cracks, blisters, ingrown nails from becoming major wounds.
Right. Stop problems before they start.
Exactly. They explain that autonomic neuropathy, another type of nerve damage in diabetes, can lead to really dry skin because the sweat glands don't function properly. Dry skin cracks easily.
Ah, so moisturizing is key.
Absolutely. Keeping the skin clean, well moisturized, pliable. They even provide a simple 0 to 2-point scale for assessing skin and nail condition, which can be tracked over time.
Another simple score. Useful.
Yeah. And they strongly recommend that for anyone with sensory neuropathy, loss of feeling, fungal nail infections, or difficulty seeing or reaching their feet, toenail care should really be done by a podiatrist or another trained specialist. Too risky to do at home if you can't feel properly.
Good advice. Don't risk an injury.
Definitely not. They also make an interesting point about calluses. Sometimes thick calluses tend to reform over sites where wounds have previously healed.
Why is that?
The theory is it might be related to the healing process itself in an ischemic environment, but whatever the cause, these calluses act like rocks in the shoe, increasing pressure, and they need regular, careful removal, sharp debridement by a professional.
So ongoing maintenance is needed.
Yes. For routine skincare, they recommend just mild soap and water, drying carefully, especially between the toes, and then using a good lubricant like petrolatum, but being careful to remove any excess residue that could become moist and irritating.
And for nails at home, if someone can do it safely?
They advise safe filing, going straight across rather than cutting, to avoid ingrown nails or cutting the skin.
Okay. Education, skin nail care. What's strategy 3?
Strategy 3 is protective footwear, choosing the right shoes and inserts.
Ah, the diabetic shoes.
Right. And it's more than just shoes sometimes. They describe a whole hierarchy of options. It starts with good quality, well-fitting, off-the-shelf walking shoes with perhaps some cushioned inserts.
For lower risk feet.
Yeah. Then it progresses up to specialized diabetic shoes with custom molded inserts, then maybe custom-made shoes, ankle-foot orthoses, AFOs, and all the way up to things like CRO boots. That stands for Charcot Restraint, orthotic walker for very severe deformities like Charcot foot.
CRO boots. Okay.
And as you'd expect, as you go up this hierarchy, the cost generally increases significantly.
I bet. Is any of this covered by insurance?
Often, yes. They point out that CMS Medicare, for example, has coverage for therapeutic footwear for qualifying beneficiaries with diabetes. Typically, it's 1 pair of shoes per calendar year and replacement inserts every 4 months, usually covering about 80% of the approved cost.
That's good to know. Helps with access.
It does, but they stress how important compliance is actually wearing the prescribed footwear consistently, and also regularly checking the feet and the shoes for any signs of rubbing or problems, and working with an orthotist to get adjustments made as needed.
Diligence is key.
Very much so.
Right.
They also mention the long recovery after complex surgery, like for Charcot foot, often involving months in external fixators or casts before even transitioning into a CRO boot or other protective device. It's a long haul.
Requires a lot of patience.
And adherence. The bottom line for footwear is that it should be prescribed by practitioners who really understand diabetic foot problems and the biomechanics involved.
It makes sense. Get the prescription right. Okay, what's the fourth and final prevention strategy?
The final strategy is proactive surgeries.
Proactive, meaning surgery before there's even a wound.
Exactly. Surgery done electively to correct existing foot deformities that are known to put the patient at high risk for developing an ulcer down the road.
Interesting. What kind of surgeries?
It can range from relatively minimally invasive procedures, things like releasing tight tendons, tenotomies, maybe minor bone work like realigning or just scoring metatarsal heads to reduce pressure, small bone debridements, sometimes even preventative skin grafting over bony areas.
Smaller interventions.
Yeah, to more complex reconstructions like lengthening the Achilles tendon if it's too tight, performing osteotomies, cutting and realigning bones, using external fixators to correct severe deformities, sometimes even unconventional amputations like narrowing the forefoot to fit better in shoes.
Sounds like major stuff sometimes.
It can be. And these more complex procedures definitely require a surgeon with significant experience in diabetic limb salvage and reconstruction. But interestingly, they note it's often the primary care physician or the podiatrist who first identifies the need for such proactive interventions during routine foot exams and makes the appropriate surgical referral.
So the primary care team plays a key role in spotting the need early.
A very key role in prevention across the board.
Okay. Education, skin nail care, footwear,
Yeah.
proactive surgery. Those are the 4 prevention pillars. That's a lot of ground we've covered.
It is. And to really bring it all home, the chapter concludes with 10 key pearls, basically, the main takeaway messages to remember.
10 pearls. Can you give us the highlight?
Sure. It summarizes things like understanding the troublesome triad. We started with deformity, infection, ischemia, hypoxia, the usefulness of the Long Beach wound score for evaluation and tracking.
Right.
Remember those 5 essential management strategies for problem wounds: wound-based protection, medical optimization, dressings, perfusion oxygenation.
5 strategies, got it.
The specific role of hyperbaric oxygen, guided by TCMs, for wounds with significant ischemia hypoxia. The value of using the wellness and goal scores, especially in complex or end-stage cases. And of course, the critical importance of those 4 prevention strategies we just discussed.
Excellent. That's a great summary of the core concepts.
So if we were to boil down the really key insights from this deep dive today, what would they be?
Well, I think it's clear that managing diabetic foot wounds and other complex wounds too really needs a thoughtful, multifaceted strategy. It's not just about slapping on a dressing.
Absolutely, you need that comprehensive approach.
And the Long Beach Wound Score seems like a genuinely valuable tool for objectively assessing how serious a wound is and tracking its progress.
Yeah, moving beyond just subjective descriptions.
Right. And those 5 core management strategies dealing with the wound bed, protecting it, optimizing the patient's health, picking the right dressing for the right stage, and crucially, ensuring good blood flow and oxygen, they all have to work together.
They're all interconnected pieces of the puzzle.
And hyperbaric oxygen, while not for every wound, clearly has a specific and important role, especially when TCMs show that lack of oxygen is a major barrier to healing.
Used appropriately as an adjunct, yes.
But maybe the biggest message, or the one that really resonates, is just how critical prevention is. Using those 4 strategies, education, foot care, footwear, proactive surgery, to stop wounds from happening in the first place or coming back.
That's where the biggest impact can often be made long-term. Saving limbs starts with preventing wounds.
So here's maybe the aha moment or the big takeaway. While these diabetic foot wounds are, without a doubt, incredibly serious and can have truly devastating consequences like amputation.
Which we saw with those statistics at the start.
Exactly. But what this deep dive really seems to show is that by having a solid understanding of why they happen, that triad, and by taking a really proactive, strategic, team-based approach to managing them, we can significantly improve outcomes.
We can really lower that risk of amputation. There's hope.
There absolutely is. Which leads to maybe a final thought, a question for you, the listener, to mull over.
Yeah.
Considering just how complex wound healing really is, with all these factors interacting, perfusion, infection, the patient's overall health, their social situation even, what aspect of this whole strategic approach that they've talked through today surprised you the most?
That's a good question. Maybe it was the maggots, or the complexity of footwear, or the TCMs.
Could be anything. What surprised you? And maybe more importantly, what further questions does it bring up for you? Maybe about your own health or the health of people you care about.
It definitely encourages you to think more deeply about it.
It does. And we really encourage you to maybe look into some of the resources we touched on, or better yet, have these kinds of conversations with your own healthcare professionals. Get personalized advice.
Absolutely critical.
Because really, at the end of the day, knowledge, understanding the why and the how, and taking that proactive approach, those are the most powerful tools we have when we're facing complex health challenges like this.
Well said. Knowledge is power.
Thanks for joining us for this deep dive today.